Hello, guys, and welcome back to the channel Therapeutic Guideline by Kurat Atif. Now, I'll be recording the latest version of chapter number 5, Therapeutic Guidelines. So, if you're preparing for exams, working in practice, or simply want to refresh your knowledge, this channel will make your journey easier and more enjoyable. So, don't just watch, subscribe now, and share this channel with your friends, colleagues, and study groups because the more we grow, the more content I'll be able to bring you. Let's make learning smarter, faster, and stress free together. So, in today's episode, I will be continuing our fifth chapter of Therapeutic Guideline, the latest version, which is version 4, and we'll be covering practical information on using antimicrobial drugs in dental practice. So, let's start with introduction. Introduction to practical information on using antimicrobials in dental practice. So, this topic covers practical information on using the antimicrobial drugs recommended in these guidelines. For comprehensive drug information, including precautions, contraindications, adverse effects, and drug interactions, consult an appropriate drug information resource. Now, if prescribing an antibacterial drug, consider the balance of benefit and harm of the drug in the individual patients. This requires knowledge of the patient's medical and medication history, including prescription medications, over the counter, and complementary medicines. Now, beta lactams used in dental practice. What are beta lactams? Beta lactams are antibiotics that have a beta lactam ring in their structure. Now, beta lactams include cephalosporins, penicillins, and carbapenems. Beta lactams have a wide therapeutic index. What does it mean? Wide therapeutic index, which means a wide difference in drug concentration between effective and toxic threshold. In most patients, beta lactams do not cause significant adverse effects. Serious but infrequent adverse effects of beta lactams include neurological toxicity, something in brain, nephrotoxicity related to kidney, hepatotoxicity related to liver, hypersensitivity reactions, and neutropenia. So NNN HH. Neurological toxicity, nephrotoxicity, neutropenia, hepatotoxicity, and hypersensitivity. All right, so these are the adverse effects. Beta lactams used in dental practice. Let's talk about cephalosporin first. Widespread use of cephalosporin is linked to an increasing prevalence of infections caused by methicillin-resistant Staph aureus, which we called it MRSA, vancomycin-resistant enterococci, which we called as VRE, multi-drug resistant gram-negative bacteria, and Clostridium difficile, formerly known as Clostridium difficile. All right. Now, cephalexin and cephaloxolin have a moderate spectrum of antibacterial activity. Now, both these drugs, cephalexin and cephaloxolin, they are active against streptococci, staphylococci, and a narrow range of aerobic gram-negative bacteria, but are inactive against methicillin-resistant Staph aureus and some anaerobes. In some circumstances, cephalexin or cephaloxolin can be used as a penicillin alternative in patients with hypersensitivity to penicillins. Okay? So we can use cephalexin or cephaloxolin as a penicillin alternative in patients hypersensitive to penicillins. Beta lactams used in dental practice, penicillins. Now we are talking about penicillins. Benzyl penicillin, which is penicillin G, and phenoxymethyl penicillin, which is penicillin V. They are narrow spectrum penicillins. So benzyl penicillin and phenoxymethyl penicillin, they are narrow spectrum penicillin. They are active against numerous oral pathogens, including Peptonephilus, formerly Peptostreptococcus species. They are also active against Actinomyces species and most Streptococcus species and other oral anaerobes, for example, Fusobacterium species. And they are inactivated by strains that produce beta lactamase enzymes. Benzyl penicillin is given parenterally for susceptible infections such as spreading odontogenic infections, and it is the treatment of choice because of its narrow spectrum of activity. So, in people with spreading odontogenic infection, benzyl penicillin is the is the choice of treatment because of its narrow spectrum of activity. Now, phenoxymethyl penicillin is given orally. For susceptible organism, phenoxymethyl penicillin is preferred to amoxicillin because of its narrow spectrum of activity. Ideally, it should be dosed at 6-hourly intervals, but for practical purposes, it is reasonable to space the 4 doses evenly during waking hours. So ideally, we should give it every 6-hourly, but we can divide the waking hours into 4 and then we can give 4 doses evenly. Amoxicillin and ampicillin, they are moderate spectrum penicillins and they are active against the pathogens treated by benzyl penicillin and phenoxymethyl penicillin, but they are more active against some gram-negative bacteria. For example, Escherichia coli, Haemophilus influenza. Like benzyl penicillin and phenoxymethyl penicillin, amoxicillin and ampicillin are inactivated by strains that produce beta lactamase enzymes. Okay. Now, combining amoxicillin and clavulinate significantly broaden the spectrum of activity of amoxicillin. So if you combine the amoxicillin with clavulinate, it will broaden the spectrum. Clavulinate is a beta lactamase enzyme inhibitor with little inherent antibacterial activity. It inhibits the beta lactamase enzymes, which is produced by Staph aureus, Bacteroides fragilis, and Haemophilus influenza, and some of the beta lactamase enzymes produced by Escherichia coli and Klebsiella species. Now, because of its broad spectrum of activity, amoxicillin plus clavulinate has a limited role in the treatment of odontogenic infection. It is used when narrow spectrum regimen is not suitable. Additional treatment, for example, metronidazole for anaerobic bacteria, is usually not required with amoxicillin plus clavulinate. Although there is limited clinical evidence to support the commonly used dose of oral amoxicillin plus clavulinate, which is 875 plus 125 milligram orally 12 hourly for some indications. It is widely used in practice without notable clinical failures. However, this dose may not be adequate to treat some pathogens, including Haemophilus influenza. For treatment of odontogenic infection in these guidelines, the recommended dosage of amoxicillin plus clavulinate is 875 plus 125 milligram orally, 8 hourly, because Haemophilus influenza is a potential pathogen. We need to memorize these dosage and the timings of all the drugs. So amoxicillin plus clavulinate is 875 plus 125 milligram orally, 8 hourly. Now, IV amoxicillin plus clavulanate is recommended for a limited number of infections in these guidelines. At the time of writing, there is limited clinical evidence to determine the optimal dosage regimen of intravenous amoxicillin plus clavulanate. For adults and children who weigh 40 kg or more, amoxicillin plus clavulanate 1 plus 0.2 gram intravenously 6 hourly or 2 plus 0.2 gram intravenously 8 hourly can be used. So if children or adult, which is 40 kg or more, amoxicillin plus clavulanate 1 plus 0.2 gram IV 6 hourly or 2 plus 0.2 gram IV 8 hourly, okay, can be used. And we are talking about IV here. Pharmacokinetic pharmacodynamics modeling suggests that both regimens reach similar target attainment. The choice of regimen is influenced by patient factors, for example, impaired kidney and liver function and drug availability. Now, for children who weigh less than 40 kg, there are few data to determine IV amoxicillin plus clavulanate dosing. In these guidelines, the recommendation reflect the dosages commonly used in Australian clinic practice with a consideration of pharmacokinetic and pharmacodynamic principles. Lincosamides used in dental practice. Now, the lincosamide, which are clindamycin and lincomycin, they are active against most anaerobic bacteria. Now, one thing I want to mention here is clindamycin is usually orally and lincomycin is IV. So they are both active against most anaerobic bacteria, for example, Peptonephilus, formerly Peptostreptococcus species, and they are also active against Porphyromonas gingivalis, Prevotella oralis, Bacteroides fragilis, and some aerobic bacteria, for example, Staph aureus, most Streptococcus species. So they are mainly for most of the anaerobic, but few aerobics also. In dental practice, lincosamide should be reserved for the treatment of susceptible infections in patients with severe hypersensitivity to a penicillin. Okay, so if the patient has a severe hypersensitivity to a penicillin, the most commonly drug given to those patients are clindamycin. There are more clinical and microbiological data to support the use of clindamycin than lincomycin. IV lincomycin can be used at an equivalent dosage if clindamycin is unavailable or if a local protocol recommends its use. Clindamycin and lincomycin, they have similar adverse effects. They can both cause antibiotic-associated diarrhea. Okay, there is a note 1 here is that severe immediate hypersensitivity reaction include anaphylaxis, compromised airway, airway angioedema, hypotension, and collapse. And severe delayed hypersensitivity reaction include cutaneous adverse drug reaction, for example, drug rash with eosinophilia and systemic symptoms, DRESS, Steven-Johnson syndrome, toxic epidermal necrolysis, SJS or TEN, severe blistering or desquamative rashes, and significant internal organ involvement, for example, acute interstitial nephritis. So these are all the things we have already discussed in our previous episode. Macrolides used in dental practice. This paragraph and this topic about macrolides, it was not mentioned in our previous, the last version, which was version 3 of therapeutic guideline. This is something new they have added in this new version. So azithromycin, is a macrolide that has a broad spectrum of activity, and its use in these guidelines is limited to prophylaxis against infective endocarditis and only in patients in whom penicillin and cephalosporins are inappropriate because of hypersensitivity. So where we can use azithromycin? First of all, it is a macrolide. It has a broad spectrum of activity, and we can use it for prophylaxis against infective endocarditis and for those patients who are penicillin and cephalosporin hypersensitive. Now, azithromycin can prolong the QT interval on an electrocardiogram, which is associated with a rare risk of life-threatening cardiac arrhythmias in patients with risk factor, for example, congenital long QT syndrome, or if they are using any other drugs that prolong the QT interval. For more information on drugs that prolong the QT intervals, we can see the Credible Meds website, not important for exam point of view. Before prescribing azithromycin, consult the patient medical practitioner to clarify whether the patient has contraindication to or precautions for use of azithromycin, for example, congenital long QT syndrome, or if they are on use of any other drug that prolong the QT interval. Nitромidazole used in dental practice. Now, the nitромidazole includes metronidazole. They has activity against all gram-negative anaerobic bacteria. For example, Bacteroides fragilis and most gram-positive anaerobic bacteria, for example, Clostridium species. So metronidazole has activity against almost all gram-negative anaerobic and most gram-positive anaerobic bacteria. Now, metronidazole may cause nausea, vomiting, flushing, headache, and palpitations if taking concomitantly with alcohol. So, whenever you prescribe metronidazole to patient, you need to ask if they are taking alcohol or not. Although clinical data on the frequency of these reactions are conflicting, avoidance of alcohol during treatment and for at least 24 hours after completing the course of metronidazole is suggested. So, if the patient is taking alcohol, you may need to advise him that stop drinking alcohol while taking metronidazole, and even after, if they have finished the course of metronidazole, they can start drinking alcohol after 24 hours they finish the course. Now, for the treatment of mixed aerobic and anaerobic infection in these guidelines, the recommended dose of metronidazole is 400 milligram orally or 500 milligram IV intravenously, 12 hourly. Okay, the 12 hourly dosing regimen is based on the pharmacokinetic data and minimum inhibitory concentration of the pathogens involved, in addition to limited clinical studies and extensive clinical experience with its use. So, what is the dosage of metronidazole? 400 milligram orally or 500 milligram IV, 12 hourly. Now, tetracycline used in dental practice. The tetracycline, which is a doxycycline, has a broad spectrum of activity, which includes activity against gram-positive and gram-negative bacteria. Short courses up to 10 days of doxycycline have not been associated with tooth discoloration. So, the concept of getting a tooth discoloration with doxycycline has not been confirmed. Enamel hypoplasia or bone deposition, even in children. So short courses up to 10 days of doxycycline have not been associated with tooth discoloration, enamel hypoplasia, or bone deposition, even in children. However, use in children who have difficulty swallowing tablet is limited because an oral liquid formulation is not marketed in Australia. Now, esophagitis can occur with oral doxycycline. So this is one of the side effect of doxycycline, esophagitis. Oral doxycycline should be taken with food and a large glass of water. And the patient should be instructed to remain upright after administration for at least 30 minutes. Okay? Photosensitivity reactions can occur with doxycycline. Warn patient to avoid sun exposure. So it says that if we are giving doxycycline to the patient, it should be taken with the food with a large glass of water. We have to tell the patient to sit upright after taking the doxycycline for at least 30 minutes. And that adverse reaction can be photosensitivity reaction can occur. So we have to advise patient not to go in the sun. Okay. Now, doxycycline has many clinically significant drug interactions. So, consult an appropriate resource on drug interactions if starting or stopping these drugs in patient taking other drugs. So, these were antimicrobials, antibacterials, now antifungals drugs used in dental practice. Topical azole antifungals used in dental practice. Miconazole and clotrimazole. They are broad spectrum antifungals available in topical preparations, either alone or they are in combination with hydrocortisone. So we have miconazole and clotrimazole. Either they are alone or they are in combination of hydrocortisone. Use of topical azoles on the skin is generally well tolerated. Now, oral miconazole gel can cause mild gastrointestinal adverse effect. Systemic absorption of miconazole can occur when applied topically to the oral mucosa. So, if you are applying miconazole on the oral mucosa, of course, it can get absorbed in the systems and then it can cause gastrointestinal problems. Azole have many clinically significant drug interactions. Consult an appropriate resource on drug interaction if starting or stopping azoles in patient taking other drugs. Now, topical polyene antifungals used in dental practice. Topical polyene include nystatin and amphotericin B. They are active against Candida species and they are poorly absorbed orally and not absorbed through the mucosa when applied topically. So, do not cause systemic effects or drug interactions. Nystatin suspension has a high sucrose content, approximately 50%, which may promote plaque accumulation and dental caries. So, nystatin has 50% of sucrose content. Otherwise, topical intraoral polyenes have few adverse effects. Taking amphotericin B lozenges after food reduces the risk of nausea. So, if you are giving amphotericin B to the patient, ask them to take after food, which will reduce the risk of nausea. Antiviral drugs used in dental practice. Acyclovir, pamcyclovir, and valacyclovir. They are active against herpes simplex and varicella zoster viruses. Now, acyclovir is poorly and erratically absorbed after oral administration and even less so after topical administration. Valacyclovir, a prodrug of acyclovir, and famciclovir. They are well absorbed after oral administration, and they are dosed less frequently than acyclovir. In Australia, valacyclovir is not licensed for use in children younger than 12 years. This line is very important. Valacyclovir is not licensed for use in children younger than 12 years. However, it is licensed internationally for use in children older than 2 years. Famciclovir is not used in children. So only acyclovir we can give. Oral famciclovir is available for adults in a single dose as a pharmacist only, Schedule 3 medicine for the treatment of mild recurrent herpes simplex virus infection of the lips, which is called herpes simplex labialis or cold sores. So if the patient has recurrent herpes simplex virus infection, oral famciclovir is the drug of the choice. Alternatively, topical acyclovir can be used, but adherence can be challenging because it must be applied 5 times per day. Topical acyclovir should not be used inside the mouth because it may be irritant. So topical acyclovir, because we have to apply again and again 5 times per day, so adherence can be challenging. Oral famciclovir we can give. This is the most given drug. Topical acyclovir should not be used inside the mouth because it may be irritant. Okay. Now this is the end of our chapter number 5. And next time we will see you with chapter number 6 of Therapeutic Guideline New Version. And till then, you study smart, study hard. And if you need me to give you some extra points, because I have noticed that these drugs, they are very well explained in more detail in the previous last version 3 of Therapeutic Guidelines. So if you want me to record that one also, specifically the antimicrobial drugs used in dentistry from version 3, old version of Therapeutic Guidelines, please shoot me a message on these any one of the recordings, and I will try to record these from the oral from the previous Therapeutic Guideline also. All these amoxicillin, lincosamide, glycopeptides, and antiviral, antifungal drugs, because they are more detailed explained in previous version of the Therapeutic Guidelines. If you want me to record this, please give me a message and I will do that for you. So till then, bye-bye. And that's the end of today's chapter. And please remember that small steps every day bring you closer to your goal. So if you're preparing for the ADC exam, don't forget to subscribe and share this channel with your friends and study groups. Together we'll make TG easier, clearer, and stress-free. Your ADC success starts here. Bye-bye.